All right. Well, welcome to this most recent episode of the Okon and Coca Report. We have the pleasure of having Ted Okon here. Mr. Okon is the executive director of the Community Oncology Alliance, and as that, he oversees the strategic direction of what is a nonprofit organization that's dedicated to patients and providers in the community cancer setting. He's a massive expert on the policy and politics of cancer care. He testifies in Congress not infrequently, and he's a real expert on the kind of the inner workings that are frequently opaque to the average, and by average I completely include us, the average clinician who's embedded in taking care of patients. So welcome, Mr. Okon. Thanks for coming on.
Dr. Koka, Dr. Cod, thank you for having me. It's a pleasure.
So, and you have a very active Twitter feed, and, I strongly recommend folks following you. And, there's some things that I think, in following you over the last few years, I can tell that, you kind of see as the pain point might not be pain point may be the right word in terms of what is causing, problems in healthcare. What, if you had to name the biggest problem you see in healthcare, and specifically we'll narrow it down to cost of healthcare because that's what we talk about. What do you see as kind of the biggest problem when it comes to cost in healthcare?
I think the biggest problem that we face now is twofold. I think number one, we have what I refer to as the Rube Goldberg system of healthcare in this country. It's the kids' game of mousetrap as a Rube Goldberg invention. It is so unduly complicated and complex that the idea that 100 years ago you'd have a provider, a physician like you guys that would deal directly with the patient is out the door because there are so many middlemen in between. And I think that what's made that worse is the fact that we've had tremendous consolidation in healthcare in this country. So if you look at on the provider side, everybody knows that hospitals are not only buying up hospitals, but buying up physician practices. And the other thing that's happening is that insurers are not only merging amongst themselves, but they're merging with pharmacy benefit managers that have merged amongst themselves. And, frankly, this is a little bit of a game that basically insurers need to consolidate because providers are consolidating. Providers need to consolidate because insurers are needing to consolidate. And what's very interesting about this is last week there was a hearing on hospital consolidation in the Senate, and it touched upon some of these very issues, regardless of what side of the aisle the questions came from. And today, you can actually see, we posted one on our website, we'll post one tomorrow, is from 2 of the 4 FTC commissioners that are actually opining now on pharmacy benefit managers and rebate rules and consolidation. And it's interesting because a lot of people think and believe it's been the FTC, the Federal Trade Commission, that has allowed all of this consolidation, especially among the insurers and the PBM. So again, I think number one problem is the fact that our system is so complex, it doesn't exist anywhere else in the world. And number two, what's making that worse is consolidation.
Thanks. What do you think? So it's interesting when we read, back in, now I'm forgetting when, 2007, 2008, cost in healthcare was, it seems like we've been talking about cost in healthcare for forever, but there was a particular surge in folks talking about it. There were Time magazine articles, and particularly I remember there was a book by Stephen Brill called The Bitter Pill, America's Bitter Pill. And he kind of went through his own experience, and he, outlined the opacity of, him going there, and then there being some massive $60,000 cost of, I don't know, a Tylenol or something that he was given. But one of the interesting things towards the end of that, and he spent a lot of time talking to many of the who's who in healthcare policy making. A lot of folks, a lot of academics, folks like Atul Gawande, et cetera. And not surprisingly, I thought it was super interesting that he came to the conclusion that, the way that this is going to be solved is by consolidation. And he specifically, pointed out a place where you spent some time, right? You went to Carnegie Mellon, UPMC. And he's said that, UPMC was going to be the insurer and they were going to be the hospital. And that would lower the cost of healthcare. Are you surprised? Now, again, the three of us here, we never quite, we haven't bought into this for a good long while that consolidation would lower the price of healthcare. Are you surprised that this is actually seriously considered by many folks in pretty high levels of healthcare policy making, that consolidation is really going to be the answer to the high cost of healthcare?
It's amazing because if you look back a number of years, there was public policy that was really directed at consolidation. And it was this mistaken belief that you'd get so big and you'd consolidate healthcare, and then the federal government would really step in and be able to negotiate with not many players, but one player. And as you mentioned, I went to what is now the Tepper School of, got my MBA at Carnegie Mellon. And, two things. Number one is, from an economic perspective and the studies that I did in economics, it's just not the way of the world. When you have consolidation, you have a dominant industry, and they're basically able to exact higher tolls. And in the case of healthcare, we're seeing that play out. We're seeing costs have escalated, not gone down. And the other thing is, you brought up the fact that I actually lived a block away from Shadyside Hospital. Guess what? Shadyside Hospital is now UPMC. And when you look at what's taken place in Pittsburgh with UPMC and the consolidation, and then you look at the battles that have gone on with Highmark for years, I mean, it's patients that have been caught in the middle of that. So it's a perfect example of it's just not working. And, all of the data out there, this came out of 4 of the 5 people who testified at the Senate hearing last week on consolidation. Surprisingly enough, 4 of them agreed. Actually, one was professor from Carnegie Mellon. One did not agree. The one that didn't agree was the head of the AHA, the American Hospital Association. But all the data is just so clear on that. I mean, in oncology, I can tell you that the data is very compelling, but we see it all overall, that costs have not gone down, that they've increased. So am I surprised? I'm not surprised as much as, I hate to say, because a lot of times I say I told you so and I'm wrong, but this was I told you so, because consolidation just drives up costs, doesn't reduce them.
And it's so fascinating how it happened, right? I totally remember reading that New Yorker article by Dr. Gawande about McAllen, Texas, right? And how McAllen, Texas, and how all these little private, these private hospitals and private strip malls, and they were like a factory of, and they're doing all these, they were driving up the price of care. And he based it on this Dartmouth Atlas of Medicare payments, right? And he compared that to going to the Temple, Mayo, and how the Medicare the cost or whatnot per person was pretty low. And then it was you're exactly right. I'm pretty sure it was Martin Gaynor, right? Who was testifying.
Martin Gaynor, that's very good. Absolutely. Mm-hmm.
Yeah, Martin Gaynor at CMU, who his group published a paper showing the other side of that, which Medicare isn't all there is, the commercial payers, and looking at what commercial. So basically, Mayo was subsidizing Mayo was charging a massive amount to the commercial payers, and that's kind of how they were doing what they were doing. So Mayo wasn't the template. So that should be pretty obvious, correct? Yet we're left with, it should be pretty obvious that consolidation does not reduce costs, that having this vertical integration and having these large behemoth systems don't create the type of scale that gets you cheaper TVs with Walmart. It just creates a massive bureaucracy, or I don't know, where the money prices just haven't gone down. Do you see?
Well,
yeah.
No. Go on. I'm sorry. You started asking me a question.
Do you see that this has been obvious to many of us for a long time, but do you see that in Congress that there is an appetite, or there is this understanding now that this is completely the wrong direction to have embarked on in 2007, 2008, based on, New Yorker articles and some small select data plucked from, the Dartmouth Atlas or whatever?
But
Yeah, there's
before
no
you
doubt.
answer,
I mean, yeah, sure.
sorry, before you answer that question, can you explain perhaps what is driving the consolidation in a way? Because you know, there's an argument to be made that if you look historically at really competitive industries, that consolidation doesn't happen. Even if you have oligarchs that try to scheme and try to get together, eventually things break down, and somebody, they'll, people will do things on their own and whatnot. And I mean, there won't be a sort of what's the term? I mean, not the conspiracy, but you know what I'm talking about. I mean,
Mhm.
so here, what are the factors that are leading? Is there actually a carrot? I mean, is there an actual policy either from the federal government or whatnot that is promoting consolidation as a good, or is it because the costs of doing business are so high that the margins are lower, and therefore the companies, whether it's the insurance companies or the hospitals or whatnot, are saying, listen, let's just consolidate, and then we'll be able to negotiate better and improve our bottom line?
I think that we talk about in DC and with legislation the unintended consequences of legislation, and I think one of the unintended consequences of the Obamacare was basically this. If you think about it, first of all, one of the driving things, and on paper it sounds great. Let's create these ACOs, or accountable care organizations. And the thinking really was that it would be physicians, especially primary care physicians, who would drive that. And what happened? The hospital stepped in, and the hospital said, no, we're going to control the action. And again, what you had is this back and forth between, first of all, the Obamacare gave some power basically to the insurers, because part of the insurers were going to step in and create the market. And then you basically had the hospitals. And again, as I said before, it was this race. If the insurers get too powerful, then they can basically dictate terms to the provider, to the hospital. If the hospitals get basically too powerful, then they can tell the insurers to go pound sand. So, you've had this escalation, and it's just clearly played out. I mean, this is factual now. It's not conjecture, that what we've seen. So look across the country and look at what we've seen in terms of consolidation in the hospital sector. And not only that, but hospitals buying hospitals, but hospitals buying physician practices. You now have a situation of where less than half of the physicians in this country are truly independent. Look at the insurer side. Look at the PBM. So for people who don't know, pharmacy benefit managers manage the pharmacy benefit, usually for employers. When you think about this, the number 1, 2, and 3 pharmacy benefit managers control now about 80 to 85% of every prescription drug. And those pharmacy benefit managers either own or are owned by the number 1, 3, and 4 insurer. So you not only had sort of these mergers among insurers to create BEMIS, and among pharmacy benefit managers, by the way, so they control prescription drugs, but now the two have come together. So what is CVS? CVS isn't just your kindly, chain drugstore. CVS now, is Aetna, and the largest CVS Caremark, the largest PBM. So you have this escalation going on that was allowed, and now basically Dr. Koga, to sort of step in and look at what you started out of asking, the appetite in Congress. Well, it's just interesting that, again, last week you had a Congress that can't agree on anything, pretty much agreeing. The Senate committee that looked at this, it said, you know what, consolidation in the hospital sector has been a bad thing, and they even brought in the insurers and this escalation. And now you have the FTC, and the FTC has been dormant basically on some of these issues. You have 2 of the FTC. Interesting, that's the 2 Democrats. There's 2 Democrats, 2 Republicans. The Republicans have been have not said anything so far, but 2 Democrats have issued statements. And in reply to Congress, the FTC presented a report on pharmacy benefit managers and specifically these rebate rules to the Congress. So what do I think? I think there's definitely some appetite. I think there's a belief that we have a problem here, but you have two problems. First of all, you have Congress, which basically can't get its act together and can't do anything. Very few things get done on a bipartisan basis. And, and number two, you just have, how do you unwind this now? How do you start unwinding these big hospital systems? How do you go about unwinding and saying, no, we have to unwind the merger of CVS and Aetna? But what's clear is data do not lie. And the data show how costs are escalating. The data show that basically not only costs are escalating, but they're basically getting out of control.
Michelle, in answer to your question, though, I mean, I think it's pretty clear that the regulatory environment was set up to engineer consolidation and specifically to go after the bad guys. The bad guys were deigned to be the community private practice physicians because they were incentivized to do more. Every time you do something, you get something. And that was seen as the fundamental thing to control. If you could control that, you would cut the cost of healthcare, right? And so that's why they thought, okay, now if we consolidate and put people into these large groups, pay people per population, so people aren't incentivized per person. But in order to do that, you had to destroy private practice. In order to destroy private practice, you started with all these, cockamamie rules of, paying the inpatient guys, paying the folks that are employed by the hospital 3 times more than the folks that are in the private practice.
And look at, you mentioned the New Yorker article. That New Yorker article, I'm pulling out my desk drawer. That New Yorker article was in the center desk drawer of President Obama. And I'm not saying this from a political standpoint. I'm just saying that was a guiding feature of what we now call Obamacare. And I think you're absolutely right. The regulatory environment and basically what that started and the unintended consequences of that legislation were what really also created a situation of where you see massive consolidation.
Right.
We're seeing it play out.
Are you seeing in Congress now after now 13 years, whatever, 14 years, are you seeing that there is that they are against consolidation? They just don't know how to kind of go about doing that, or is there still some debate about consolidation being good or bad?
I don't think there's a debate. I think the problem is, and again, last week's hearing was pretty telling. I think there is a belief that there's a problem here. You have to also realize that the adage around Congress is that if you look at any congressional district, the 2 biggest employers and most influential are car dealers and hospitals, right? Right. So you have a very powerful lobby, especially at a House congressional level and even at a state level of hospitals. So that presents a problem. And then you just simply have, even if Congress can agree on something, they always disagree, especially in this environment coming off of last year. I mean, you would think after a pandemic, a public health emergency, a once in a century event, that basically you would have Congress come together like they did after 9/11. But they're so polarized, especially because of the prior administration and President Trump and what's happened over the whole voting thing and certification or decertification. I've been up on this hill for 20 years and I've never seen it as polarized as an armed camp as I see it today. So regardless, they all think they all agree on something. Even if they can agree on the solution, the problem is it's a really tough place right now.
What would you do before we move on to the next thing? What would you do? Say you had the power to free Congress from their polarized paralysis. What would you have them do to tackle consolidation?
Well, I think on 2 ends. I think on the hospital front, I would really significantly clamp down on, hospitals. Nonprofit hospitals are basically given so much in terms of nonprofit status when they're really not nonprofits. and things like these 340B discounts. If you look at what hospitals are making on drugs, so I would level the playing field. I'm a free market guy, so I wouldn't go in and start saying, okay, we're pulling you apart, we're pulling you apart. That just can't work. But what I would do is I would really level the playing field, and I would be very, very concerned about the mass migration of independent physicians into the hospital setting. And I would go even overboard on the physician side. And if you look at it, because of that New Yorker article, Gandhi New Yorker article, that created a situation of where they went overboard on the hospital side. So number one, on the provider side, I would do that. And the other thing is I would come heavy down on PBMs. They are literally a plague. And what would I do there specifically? I would take rebates away. Rebates are basically a license or a waiver to basically have a certain drug being used, and they are a lifeline of right now of these PBMs. And I would do everything to basically knock down the PBMs. If you look at it, it's very slow to happen on a federal level, but at the state level,
sorry to
Yeah.
interrupt. This is fantastic, but just so we don't lose folks.
Yeah.
Say you're a private practice oncologist. There's a drug that you want a cancer drug that you want to give somebody with some GI stromal tumor. Just walk me through how that private practice tries to acquire the drug, how they pay for the drug, and the role of the PBM in that.
Well, it's interesting because it's on two sides of the drug. So number one is in oncology right now, about 40% of the drugs are oral. And that's why these PBMs are really attracted to it. The rest of the drugs are not just your typical age-old chemotherapy, but your IO, your immuno-oncology drugs that are basically infused. And what's happening now is that in a normal situation, basically the oncologist in private practice, that practice will purchase the drugs and purchase the drugs so that, people say the adage is, oh, they purchase the drugs so they can then, sell them to the patient regardless of whether they were. No, they do that because it's just in time inventory. So when that patient comes in, especially if that patient has to be changed because the tumor is not reacting to a drug. And again, whether it's an oral medication in their pharmacy or whether it's a infusible medication, the bottom line is it's right there. And then the physician bills that. Now, especially with this consolidation with the insurers and the PBMs, the insurers want to tell the oncologist what drug to use. In fact, there's something called step therapy, which is a fail-first mechanism that says you have to try drug A instead of drug B, or drug B instead of A, even if you want to use drug A, because the patient has to fail on drug B first. And so they not only want to be able to tell the physician what to use, but then they want to tell the physician where to get it from. So if you take a look at CVS Caremark, you have Aetna, basically the insurer arm of CVS Health, basically saying what to use, and the patient has to fail on a drug first, or only so many drugs are on a formulary. And then you have Caremark, which is the pharmacy benefit manager, not only saying when the drug is an oral drug specifically, saying that basically this is how you're going to get it, but where you're going to get it from. And guess what? Where you get it from comes from CVS's own mail order pharmacy as well too. So you can see the consolidation, which is driving that. The problem is, when you're the patient, basically the patient is not getting the optimal medication. And then we have horror stories of the patient basically getting delays and even denials of getting their medication because they can't get it right from their provider. It has to be sent through the mail to them. So this is the kind of thing that's not only sort of disrupting the economics, but it's disrupting patient care.
But specifically, what drugs are the insurers incentivized? Oh, sorry, the PBM insurer kind of monster complex that now exists, what drug is incentivized to be used for the patient? Is it, you're saying it's not the best drug for the patient?
It's
What
not
are
the
the
best
incentives?
drug. It's not the least expensive drug. Guess what? It's the most profitable drug to the insurer or the PBM. And that's where rebates come in. So rebates are basically a form of extortion. Look, I'm never going to let the drug industry off the hook in terms of prices are too high. There are problems in some of the practices that the industry, but let me first say that what a PBM does is goes to a manufacturer, and I've heard some real doozy horror stories, and said, if you don't give me this rebate of 50%, then your drug is never going to see the light of day on my formulary. Now, some manufacturers play into that, and basically they build up what are called rebate walls that make their drug the preferred drug, and it's hard to surmount those walls at all with a competitor drug. So this is the kind of thing that we see going on. And you would think that PBMs are, their mantra out there is we save money. But what they do is they make profits. And how they make profits is making sure that the drug that is specified and dispensed is the most profitable drug to them. And in many cases, that's not the most effective drug, and it's also not the least costly drug. And one thing I want to say there is, if you look at, especially true in oncology, but you can see it in other areas in medicine, rheumatology, ophthalmology, can go down the list of drugs where, why is the list price so artificially high to what the net price is? So we have a gap that's growing in this country of list price and net price. Why is that? Because the list price is the price that the PBM basically takes the rebate and gets the rebate off of. But the problem is all of the patient's cost sharing is based on the list price, not the net price.
Right. So, right, exactly. So,
I know this is, and let me just stop and say, I know some people listening are probably, their heads are spinning because this gets to be so wonky.
Yeah.
It gets to be so complicated. But like I started out when you asked me the question, one of the biggest problems with our healthcare system, this is how complicated it's gotten.
Yeah, but I mean, it's not. Yeah, it just, we lay it out. Basically, one of the issues for PBMs is that part of how they're allowed to be reimbursed is based on the rebate, based on the savings that they're able to get, right? And so that incentivizes. So if the drug is $1,000 a pill, and they that's the list price, right? And then they get the drug for $500 a pill. That's a pretty massive saving there, and they get paid a function of that difference. So that incentivizes the manufacturers, of course, to have these massive list prices, because then everyone wins, right? The only person that doesn't win in that whole scenario is the patient, and I guess the person who eventually pays
paying for it. Yeah,
right. Who's paying for it?
So
right.
Employers, whoever is paying for the drug. Yep.
Right.
But the thing is that what everybody has to remember, and again, I'm a free market guy. This is not a free market system, because normally you can't use that kind of, a rebate is a waiver in the system. It's not allowed. The reason why it's allowed is because PBMs basically have that waiver that allows them to use rebates in terms of discounts, which go back to drug selection. So that's why one of the things that has to happen here is getting rid of these rebates. They are a real problem in this country. And let me just say one other thing. So one of the things that you saw that President Trump tried to do, and you have it in the Pelosi bill, which is the Democrat House bill to tackle drug pricing, that came up in the last Congress, has come back in this Congress, is this idea of reference pricing to other countries. And I know some people say, well, wait a minute, why does Spain or Greece or the UK, Germany pay less? part of the problem is we're talking about, and again, I'm not letting the drug companies off the hook, but you're talking about apple and orange prices. So when you look anywhere across this globe, and I have traveled to India, China, Singapore, the UK, Abu Dhabi, Dubai, I can go right down a list of countries looking at oncology practices years ago. The bottom line is they don't have systems like ours. Obviously, in many of these, you have government control and government bids, but you don't have PBMs. You don't have all these crazy discounts and mandatory discounts and rebates that we see here, which create a gap between list price and net price. So it's a little bit unfair. It's a little bit misleading to compare our prices to other countries because in many cases it's apples and oranges.
Right. So you're talking about the Trump proposal. It was supposed to go into effect January 2021, but in part because of a letter from you and pushing from many folks, this most favored nation, which is basically reference drug pricing, to say that you could not, Medicare will not pay more than whatever some amount that's being paid to. It actually was developed countries. They excluded the developing countries, or whatnot. But again, the problem is that the easy workaround there is that they'll just raise prices all over, I guess, right? So it doesn't seem like a good long-term sustainable model. But basically, from a PBM standpoint, right, you would eliminate the ability to get paid as a function of the rebate. But what about, which seems like a great idea? What about the incentives for folks in private practice? And full disclosure, me and Michelle are both in private practice. What about the incentives? The other side says that, look, the incentives for private practices to choose expensive drugs rather than generic drugs is much higher, because the way private practices, as I understand it, in the oncology world, get paid, it's the average sales price plus 6%, right? So 6% of 100 is a lot less than 6% of 10,000. And so what's to prevent a oncologist from always choosing the much more expensive drug, because they're going to get paid a lot more for that?
Well, there's a couple of things. First of all, it is not, when you look at drug by drug and you take some of these drugs, it is not an even state in terms of the fact that every drug you make that, in essence, that plus over the average sales price. And by the way, it is 6% in law, but it's in actuality 4.3%, because years ago the government couldn't work out their budgeting, and something went into effect called sequestration, which knocks down all Medicare payments by 2%. And so in Medicare, 80% of the drug or the service is paid by the government, 20% by the individual, directly or through their coinsurance. But the bottom line is the 2% on the 80% means it's really 4.3. But if you look at drug by drug by drug, and just look at it on a purely economic basis, you'll see that there are some drugs that, in the nature of the ASP, are even underwater. It's not an even state in terms of what you would think. And then the other thing that comes into play is you would say, well, wait a minute, hopefully physicians like yourself, and not all physicians are perfect, just like not all politicians or executive directors or media people. But the bottom line is that they're going to give the drug that's the best drug for the patient. The other thing is, because the oncology practice is, in essence, stocking the drug, there's a high cost. The more expensive the drug, the higher cost of stocking the drug. The real story here that's so interesting that has finally come out is the problem isn't on the practice side. And by the way, if you think about this, in 2003, 85% of all the cancer care in this country was delivered by independent oncology practices, with the remainder on the hospital side. Right now, that's gone to 55%. If this ASP plus six thing, that's ASP plus 3, was such a great deal and a moneymaker, then why has it gone from 85% to 55%? And the real startling thing that we've seen is that This year, January 1, what went into effect is a rule by the Department of Health and Human Services that required hospitals to not only report on their charge masters, which they've had to do for a couple of years, what their list prices are, but had to report specifically on their top services and drugs by insure, and literally basically what they were making. And if you look at a Sanford Bernstein report, which is an investment research house that came out in the middle of January, they looked at the first hospitals reporting on that, and the average markup on drugs, and they were mostly oncology drugs, these big, huge oncology infusible drugs, was 250%. And by the way, that was 250% compared to the average selling price, not what their real discounted 340B price was at all. So it's a lot higher than 250%. But what it showed was, number one, that they were using the more expensive drug. And now that we have more biosimilars, which is I don't want to say a biologic generic for anybody who doesn't understand, but it's the closest thing to a generic to a biologic. But now that we have more biosimilars in oncology, you have two contrasting things. And if you think about it, biosimilars are less expensive. On the independent practice side, that's where the real uptake in biosimilars are. And the data shows that. In fact, even Sanford Bernstein did a report on biosimilars. On the hospital side, this initial report from Sanford Bernstein found that between 31 to 43% of the hospitals did not even stock any biosimilars. They just stocked the originator product. And why the report concluded is because hospitals have this incentive to use the most expensive product. So, it's really a tale of two cities,
so you're
if you
saying
will,
that
between the independent side and the practice side, and what the data actually shows.
Yeah. So you're saying that, yes, independent physicians may have this incentive, right? But there's no question that, and the data shows it, and not much to argue about there, that the hospital systems are way, 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 way worse and mark up more and have do this in a much more inefficient way. Can you explain? I guess I don't understand. How is it that they're able to mark up the price 250%? I mean, you can't do that as an independent physician, right? I can't buy immunotherapy drug for $100 and then charge the insurer $350 for it. How do the hospitals do that?
Market clout. So if you look at market by market, and what's so fascinating about this report is it shows, I'm just going to take an example. It shows, hospital A that charges a different price for Keytruda, an oncology IO drug, to Aetna than it does Humana. And it shows the variation in prices to different insurers, and it shows the markup over ASP. And this gets back to our theme of our talk here. It's all about consolidation. Wow. And so when you look in different markets, there are certain markets where the hospital system is the dominant, basically has the leverage over the insurer. And then you find some markets where the insurer has leverage over the hospital. But for the most part, hospitals have more leverage, and it has come out in this report when you realize how much hospitals make on these very expensive drugs.
Explain to us 340B pricing. This is a beautiful tale. I love the tale about how do-gooders at some bureaucratic level come up with some beautiful plan in their academic lab, and but the practicalities of it are result in basically everyone being worse off. So explain how the 340B pricing for those who may not know.
This is the one of the clearest stories of unintended consequences of legislation that there is. So I'm going to give you the fast story, but basically it's fascinating because back in 1991, pharmaceutical companies gave voluntary discounts. And not that they were great guys, I'm saying, but literally there were voluntary discounts. And then what happened is Congress created Medicaid best price, which basically says that Medicaid gets the best price on drugs. And if the price is lower anywhere else, Medicaid vets that get that best price. Well, guess what? A free drug is a zero price. So all the voluntary discounts stopped then. And in the intervening year, Congress was concerned that basically there were patients who would not be eligible for Medicaid, but would still be, in need enough that basically they'd have to get some kind of discount on the drug. So they took a very easy step and said, look, we're going to give a handful of hospitals in this country basically discounts. If a pharmaceutical manufacturer participates in the Medicaid program, then they have to give discounts to these safety net hospitals. And it happened to be section 340B of this bill. And so fast forward, we're now in a situation where over half of the hospitals in this country have 340B discounts that range in upwards of 50% of these very expensive drugs. So it's become now a way of a hospital system, which, by the way, hospitals that have 340B do not have to give the discounts to patients. They do not have to account for the 340B dollars. It is a variable black hole. And I can guarantee you, every time you read a news story, whether it be, the news stories about Methodist in Memphis or UVA system in Virginia, Northwell in New York, that are going after patients very aggressively in debt collections, they end up being 340B hospitals. So 340B is literally it's like an ATM in the basement of the hospital. They just literally print money. And so you say, well, why are oncology practices in particular getting gobbled up by hospitals?
So you're saying that a hospital that gets a drug for 340B pricing because they're in that geographic area, they can then use that discounted price, not just for their Medicaid or uninsured patients, they use that drug for the patient with IBC who comes in.
They use the drug to fund CEO bonuses, to put a new grand piano in a lobby, to build a building. Literally, I can tell you stories about 11 oncologists, independent oncologists, sitting in a room listening to basically a CEO saying that they're building their new building on 340B dollars. About 8 years ago, I was in Puerto Rico. I speak every year to the oncologists in Puerto Rico. They had me down to the island, and they also had down a medical director from a 340B hospital. And he was very naive, but he spent half the talk saying, "Hey, you guys in Puerto Rico, you need to be 340B because we made $117 million last year. In fact, we're making so much cash that these venture capitalists want to come in and private equity people and buy up the hospital." The stories are just absolutely startling. And let me tell you one other thing. Again, this is a tale of two cities. So basically, on one hand, you have federal grantees. Those are community clinics, Ryan White Aid, hemophilia, that depend on these 340B discounts. They're called federal grantees. Guess what? They have to say, where are the discounts going? How are the discounts being used? How are they being used specifically to be given back to patients? They have to disclose all that. On the hospital side of 340B hospitals, don't literally disclose a thing. No one knows where the dollars are going. And let me just before you had interjected, look, the average oncologist, depending on the type of cancers he or she is treating, may account for $5 million in drugs. Let's use a round number that actually is a real number, $5 million in drugs. Well, if the hospital is getting 50% discount on those drugs, that means that every oncologist represents $2.5 million each year to that hospital. That doesn't even include the other services and the administration, chemotherapy, everything that's more expensive than the hospital makes more money off of, or as you guys know, facility fees, literally just by the drugs. So there is a powerful incentive for hospitals basically to build up one of their programs that uses the most expensive drugs, and that's oncology.
Wow, wow. It's stunning that this is allowed to happen. I mean, it's like a legalized. I mean, yeah, I mean, it's unbelievable. So why is the solution not to all this? You know, you're talking about it's this opaque system. I mean, you know, you can't understand it. Most people can't understand it, and that's why all this stuff gets hidden, and is therefore perpetuated. Why is the answer not for the federal government to just fix the price of all the drugs?
Because not just because I'm a market guy, but price fixing has never worked in the history of humanity except on a short time, literally wartime footing. So it's one thing when you put in wage controls and price controls that basically you have to because you're on a wartime footing. But literally in human history, that's why when you look at many socialist countries, and the more socialist they are, the problem is, I'm not talking about drugs, I'm talking about food and cars and everything else are not available because you're literally fixing the price of drugs. So even though I believe that drug pricing is a problem, I've said it publicly, I'm saying it here publicly, I've been quoted in the press, I've told more CEOs behind the thing, drug pricing is a problem. The key is it shouldn't be that price fixing is not the answer. We will destroy basically the advances we've made, especially in cancer, if that were to take place. And again, I'm not taking the defense of the drug company because I'm very critical of some of the pricing.
What would you say to? Oh, sorry. Go ahead, Michelle. Go
ahead. Do you speak to employers?
Speak to employers all the time. We actually at COA, the interesting thing is we have formed a separate entity to literally just work with employers, and where we're headed is to actually pull together practices in a clinically integrated network, which is a legal way of actually contracting directly with employers. So we are talking to employers and we are looking ultimately to direct contract. Why? To get the middleman in the way. You talk to employers, right. And by the way, more employers, the trends are right, are self-insured. And so they're not satisfied with even the insurers. The insurers act for the most case of just processing claims. But the insurers aren't, and the employers aren't happy, and the employers want solutions. And that's why we're talking about direct contracting.
No, that makes sense. Because, you know, a few months ago, we had on our show the executive director of the Free Market Medical Association, which is essentially a lot of ex, born again, they were ex insurance brokers. And then they realized the shenanigans and they said, no, we can't. We're not doing right to the employers. And with more and more self-funded employers, it makes sense to steer them towards, a direct contractual agreement with outpatient surgery centers. So there's a movement now of outpatient surgery center. A lot of primary care physicians are going on direct, relationship with patients and maybe with employers as well. The specialty market, the specialty medicine has not caught on yet, but for oncology, it seems that it would make sense. I mean, oncology is reasonably predictable as an expense. It seems to make sense for employers to maybe contract with independent, oncology practices and things like that to work that out in a way that be a lot more sensitive.
And I'll tell you, and I will tell you, we've been working on value-based care, both on the services side and also on the drug side. So we're putting ourselves literally at risk, in terms of saying we'll provide value and show value, and saying to the drug companies the same thing. So the fact of the matter is, you basically all go in it, you all have true skin in the game, and you base it on value. And that goes back to basically what we were talking about before, is why don't oncologists use just always the most expensive drug? Because they're now in more of these value-based arrangements. So if you go to the CO website, you go to our CO website, you will see a map of the United States. And that map of the United States, it's interactive basically. When you go hit a state, you will see the payment reform models in that state. We're now tracking 35 different payment reform models. And it shows you the commitment to oncology, and specifically independent community oncology, to payment reform. So, as I like to say, talk is cheap, but basically, action says everything, and we're showing it in terms of in terms of actively payment reform. And that's what employers want to see.
Very good. What about patients? You speak with patients, obviously. I imagine. I mean, you speak for patients, so, but it's a harder constituency to speak to. Once they have cancer, they're sort of, maybe their minds they're preoccupied, and when they're healthy, it's not on their radar. How do you educate the public? I mean, that seems difficult.
Well, two things. It's always about patience, and let me tell you, when I forget that, or the perception on my wife's part is I forget that, let's put it this way, it's hell to pay. Because my wife was an oncology nurse for 10 years. She retired at the end of 2019, nothing to do with me. She was an oncology nurse, and it's all about patients. And I really hope to say that our first constituent is actually patients, not practice as oncologists. But it is tough. So we have actually a patient advocacy network that is run by a woman who is a 15-year breast cancer survivor, obviously very, very, very passionate about it. And we spend a lot of time with patients to let them know this is the impact of what's happening to them. And, to give you an example, the way we look at this. So, I'm tired of basically, as I told before, these PBMs saying, no, you have to get a drug from our mail service, and listening and seeing patients that basically cannot get the drug in time. So we worked with two members of Congress, and by the way, bipartisan. So Congresswoman Terry Sewell from Alabama and Congressman Gus Bilirakis from Florida. Congressman Bilirakis is the Republican, Congresswoman Sewell is the Democrat. And they introduced a bill called the Tact Act and the Timely Access to Cancer Treatment. And it says that if the PBM says that you have to get the drug from us from our mail order, that they have to, number one, go through the prior authorization, which, as you guys know, is you basically calling up and getting the blessing of the insurer to basically say, yeah, you can use this drug. And the drug has to be to the patient, well, the prior authorization and everything within 72 hours, or the patient can decide where they get their drug. Presumably they'll go to their oncology practice where they would normally want to get it anyway, but whether they go to the specialty pharmacy, local pharmacy, whatever, if the drug stock, it's the patient choice. And it gets around this idea of we're not going to sit around and let patients get delayed. So as a part of that, it's educating patients. And there's so many patients out there that we've written 5 volumes of horror stories on this, of patients who can't get their drugs. I sat in Senator Cassidy, who's a physician's office, 2 years ago, and listened to a son and a daughter of a woman who fought with the PBM for 2 months to get her drug. She finally went into hospice. The week after hospice, she went in, she got the drug. A week later, she died. And, they're sitting there crying. Senator Cassidy's crying. I'm crying. All the staff is crying. And they said, look, I'm not saying that my mother got the drug. She would have all of a sudden, it would have been a miracle. She would have lived. But my mother was burdened with cancer, and it was hard enough fighting cancer, let alone fighting the PBM to get her drug. So it's tough, but more and more patients, the one good thing about Obamacare and the ACA is after that, healthcare went from that the average person wasn't involved in it all to the average person was very involved with it. And so we have more patients that listen, and we spend a lot of time with patients and educating and helping them.
Right. Anish,
this has been really fantastic. So thank you so much we've taken up, we're nearing an hour. So this has been illuminating, and I hope, I'm sure listeners have gonna understand a lot more about healthcare and the capacity behind it. And
well, I hope some of it gets so wonky. I just hope it wasn't too much in the weeds of wonk. But unfortunately, that's the way our system is.
One last question. The natural. I'm sure you've seen that chart. Everybody has seen it, where you have the growth of the administrators and the growth of physicians since the 1980s. That was passed around as a meme, and most of the free market pro-free market people say, oh, you see, it's right, this bureaucracy and whatnot, it's terrible, leave it to the free market. But it turns out that the graph itself was put together by the Bernie Sanders people, right? The people for single payer healthcare, who claim that if you have just the government not just fix the price, but just to run the whole show, then you can get rid of the administrators and whatnot, because it'd be much simpler and so forth. And what's the appetite right now that you sense in Congress for a single payer system? It seems that we're not hearing about it as much as we did a couple of years ago.
Really tough. It really tough. It's something that I think would have a great difficulty even coming out of the House. In fact, about 12 House Democrats wrote a letter to Speaker Pelosi on her bill, which has elements of that in drug pricing, and saying basically, in essence, we're not going to vote for it. So right now it's stuck even coming out of the House. And then you get over to the Senate, and you got some moderates over the Senate that just won't vote for it. So right now, the idea of a single payer system is pretty much dead in the water. I think the one thing that may get a little traction, and it will be interesting, they'll certainly put a big push on, is lowering the age of Medicare from like 65 to at least 60, if not 55. That's something that's making a lot more noise than the idea of a single payer system. And, by the way, part of the problem is, and I have some friends, physicians, they're enamored with this idea of single payer. It will take care of everything. I mean, do you know how much the once again, the postage is going up in this country, I think on July 1st. I mean, the problem is when you really can't run the postal system, it's really hard if you're going to say you're going to run all of healthcare. Right. And so I think it's something that the politics aren't there. And from a practical standpoint, it's a great political message, but I don't think it's going to happen.
On that note, thank you very much for joining us.